Thank you. For those who, well, first, I don't have any affiliation to disclose. And for those who don't know us, Lymphoma Coalition is the global network for lymphoma patient organizations. And I find very, very difficult to cover this topic in 10 minutes. I will do my best, but I ask you, Sophie, please to tell me when I have 3 minutes. And not one, because I will collapse if you do that.
Kick you off.
Yes, please. So, just to establish the barriers of my talk, I will try to cover some of the gaps in the patient journey that are related to the performance status and to things that may be addressed from rehabilitation and rehabilitation, telling you some of the benefits, but also the evidence behind that. And we will discuss how we can overcome frailty after all. You may think that this slide is about my luggage that went to Madrid, to Amsterdam, then to New York, then to Boston, and now it's going to be back to Madrid, but it is not. It is to tell you how hematologic patients feel regarding performance status and ways to address physical and psychological symptoms after diagnosis and during treatments and till the end of life. And this one is really shocking when you realize that no hospital sends a stroke or cardiovascular patient home without a detailed plan to help them regain as much as their normal functioning as possible. But yet, hematologic and cancer patients are regularly diagnosed, treated, and released with no guidance on how to deal or how to address the impairments that may linger once the treatment starts, during the treatment, and after the treatment is done. If we try to analyze all the symptoms that impact hematologic diseases and treatments, we may move through from cognitive or memory impairments to physical things as bone loss, muscle loss, weakness, decline in walking speed, some gait dysfunction, which make, of course, the patient less active, nausea, fatigue, lymphedema, sleep disturbances, peripheral neuropathy, myelosuppression, joint damage. Lot of neuromuscular disorders, especially in hemophilia, in thalassemia as well. And if you study after a review of literature, we see that there is a growing body of scientific evidence that supports that newly diagnosed hematologic patients may optimize their status performance before starting acute treatments and even before starting treatments. And research shows now that multidimensional interventions can help people reduce disability and improve their functioning. And that's why this presentation is about. Rehabilitation is the process on the continuum of care that occurs between the time of diagnosis and the beginning of acute treatment. And rehabilitation starts once the active treatment has put in place for the patient. But this is to mind that gap. What really matters is what we can do first, what we can do before the treatment to start, to assure that the patient can achieve the best status performance possible, and then to help them, of course, during the treatment. Among the benefits, we can mention improving physical and emotional health before treatment, but also reduce treatment-related morbidity. And some studies talk about improvements also in mortality rates, decreased length of hospital stay or readmissions, which is very important from the cost-effectiveness perspective as well. And increase available treatment options for patients who would not otherwise be candidates for active treatment. And I think that this touches very much in our hearts, because we know that many people or many patients are tagged as frail, so probably they don't receive active treatment for their disease. But both interventions must start with a physical and psychological assessment and social assessment as well to establish that baseline of functional level to identify impairments and provide that valuable information to design targeted interventions that improve the patient's risk to reduce that status performance. Research in general supports a multimodal approach, including physical focus, psychological and social focus as well, and also nutrition. And when we talk about nutrition, we must consider all the potential interventions from nutritional counseling, supplementation, enteral and parenteral. And what we have at the end is a big picture of how rehabilitation and then rehabilitation once the treatment starts may improve baseline status and combine with that rehabilitation during the treatment may at the end modify the final outcomes. But if we move, or I want to move to some specific examples, and I brought the bone marrow transplant exercise program because this is something that I have experienced myself with patients, but also because it touches most of the diseases. This means that this intervention means that we start some exercise, adapted exercise, of course, specific tailor for each patient, must be personalized, pre-transplant, and we will continue during transplant and after transplant. And when you talk about exercise, probably you can imagine how some patients during the transplant or in that moment when you are so weak can really exercise. But exercise, the difference among exercise and physical activity is that you provide a structure and you provide progression and you provide a mode. So you can do that even lying in a bed, because what really matters is how it's organized. And what we found is 50% improvement in fatigue scores with exercise against 28% deterioration in fatigue scores without exercise. But for example, cardiorespiratory fitness improve in a very effective way, and also global quality of life, and also the lower and upper extremity muscle strength. If we move to hemophilia, for example, we see that patients with severe hemophilia will have 5 damaged joints by the age of 20. And this is really hard to accept. But physiotherapy and rehabilitation help to prevent disabilities and even to prevent bleeds. Just to mention one case study, this is an adult hemophilic patient observed for 8 years with 2 types of deterioration and bleeding. And he presented knee joint contracture and joint instability. So through the program, once the program started, the focus was the increase the range of motion of the joint, improve the stability, and strengthen the muscle. And not only the function of the joint was improved, but also the bleeding stopped. The high proportion of adults with thalassemia experience fatigue, chronic pain, bone loss, fracture risk, and rehab prevents disability and deterioration of quality of life, but also provides, even can help in that control of anemia, having the many of the processes in the body working as if they should do. Just to mention frailty, what really matters is that frailty is, or frail, when you tag a patient as frail, you probably would treat it completely different, or you won't offer treatment at all. And of course, frailty is related to the aging process, but not necessarily age defines specifically what frailty means. We need also to understand the the tumor characteristics or the disease characteristics, the organ function, and what really matters is the performance status of that patient. Everything should start, again, with an assessment and must be multidisciplinary. And it's not only for geriatrics, it's also for every patient, because even young adults who, after a diagnosis of cancer may be defined as frail patients. It's important to develop one tool specific for hematologic malignancies to consider all the dimensions, musculoskeletal, cardiopulmonary, neurological, and to establish a common language to classify those older patients, but also those frail patients in general. And the importance is the answer that we will get from this assessment that will bring that important information for hematologists and also for all the multidisciplinary team to design specific tailored interventions to overcome that frailty. But of course, we have some barriers to establish this. One is the misconception of tolerance to cancer treatments, which is changing a little bit now. Then the underrepresentation of frail or older people in clinical trials and screening programs, and the lack of criteria that we are actually find in specific guidelines. What the evidence says then, exercise interventions has a positive functional impact reversing the frailty on older adults. And this is from 2014, so it's not too far from now. Improves cardiorespiratory, muscle function, physical activity, and functional independence. But also, again, we talk about how some of the characteristics of the physical performance of the patient can be described as those you use for fit patients.
30 seconds.
Is the last one. So what really matters is that frailty is not exclusive of older patients. Even children may have this. And we have some barriers. Probably I will highlight that some patients and even physicians think that they have no problems, and no problems meet no needs. And just to mention one take-home messages, well, three. I want to bring a phrase from the chair of ASCO Survivorship Committee, Kevin Offener, who says that rehabilitation is probably the single most underappreciated service among cancer survivors right now, and must be, as I mentioned before, multidisciplinary, and must be incorporated also in guidelines. That's probably the key point to change this in the near future. So never stop being curious about this topic.
Thank you ever so much, Natacha. Sorry for rushing you.
No, it's how it is.